Hello guys. So now that we are done with all the other parts of the body, so the last part, that is pelvis, we'll be discussing here. So first thing I'll be discussing here is about urology. Okay, so then we'll discuss about obstetrics and gynecology. So to begin with, we'll start a little bit about the anatomy of the pelvis. Okay, so anatomy of the perineum is very important. Okay, so in anatomy of perineum, please note that there are two triangles. Okay, so two triangles in the perineum. Okay, one is the anterior triangle and the other one is the posterior anogenital triangle. Okay, so there are layers when so in the perineum there are layers to reach the pelvic organs. Okay, so from below is what we are taking a look at. So the first thing is there will be skin, then the superficial fascia, then the superficial perineal pouch will be there. Okay, so in this particular perineal pouch there will be bulbospongiosis, ischiocavernosus and the transverse perineum. Okay, superficial transverse perineum will be in the superficial perineal pouch, whereas after that there will be a perineal membrane. Then deep down to that there will be the deep perineal pouch. Okay, so in deep perineal pouch there will be deep transverse perineal muscle and external urethral sphincter will be there. Okay, so this is all with respect to anterior anogenital triangle. And the pelvic diaphragm will be to both the anterior anogenital triangle and the posterior anogenital triangle. So the inner part after the deep perineal pouch will be the pelvic diaphragm. Okay, so that is levator ani and the coccygeus muscle. Okay, levator ani consists of three muscles. Please remember this. Okay, this is very important: iliococcygeus, pubococcygeus and puborectalis. Okay, this is what forms the levator ani. Okay, iliococcygeus, the pubococcygeus and the puborectalis. Okay, then coming to some of the important notes with respect to the pelvis is, so collis fascia, basically we discussed, right? Collis fascia is the superficial fascia just below the skin. What happens is it prevents the extravasation of urine into the thigh. Okay, so during any blunt injury or urethral injury, so this is the fascia that prevents it into going into the prevents urine into going into the thigh. Okay, then there is something known as Allox canal, also known as pudendal's canal. Okay, pudendal canal is where the pudendal nerve will be passing through. This is very important for pudendal block that we give in anogenital procedures. Okay, so this is very important. So this is what during episiotomy, this is what our target is. Okay, we're identifying the pudendal canal. Okay, then so basically this is present in the posterior anorectal canal. Okay, formed by the fascia of obturatus internus. Okay, so this forms the pudendal canal. Okay, content will be basically neurovascular bundle, mainly the pudendal nerve. Okay, then significant is it is because of for the neural block. Okay, pudendal block during episiotomy and all. Okay, so now coming on to the specifics of nephrology. Okay, we'll be dealing about nephrology and urology here, and then we'll go on to obstetrics and gynecology. Okay, so here in this chapter we'll go for nephrology and urology. Okay, so to begin with, we'll deal with the embryology first, that is development of the kidney. We know that, right? We had discussed mesoderm has three different regions, that is paraaxial, intermediate and the lateral plate mesoderm. So it is the intermediate mesoderm through which the kidney develops. Okay, so intermediate mesoderm will give rise to nephrogenic cord. Nephrogenic cord has three different parts, that is pronephron, mesonephron and metanephron. Okay, so pronephron will be begin in the starting of the kidney development, but it will be degenerated and it is non-functional. Okay, so our importance is for mesonephron and metanephron. Okay, this will be start developing at around 4 to 5 weeks of gestation. Okay, so mesonephron will form the temporary kidney. Okay, and it will give rise to mesonephric tubules and duct. Okay, this is also known as Wolffian duct. Okay, please remember the name Wolffian duct. Then coming to metanephrons, so this will form the definitive kidney. Okay, so this will give rise to metanephric blastema. Okay, so we'll come back to that. Okay, so now the mesonephric duct, that is the Wolffian duct, will give rise to the spermatic pathway and the ureteric bud. Okay, so this is the thing with respect to mesonephric duct and the metanephric duct. So now metanephric duct will form the definitive kidney. What is the definitive kidney? It is basically all the nephrons, right? So all the nephrons till DCT. Okay, all the nephrons. Okay, so for example, let us take this is the different millions of nephrons are there. So this is the nephron part of the kidney that is being formed. Okay, so now the Wolffian duct will give rise to the ureteric bud. So what it does is, so from the collecting duct, so all the collecting duct will together form the renal pelvis, right? So renal calyces and pelvis. Okay, so renal collecting duct will form the pelvis and the calyces first, and then the renal pelvis, right? So that is how the development of the kidney will be, and finally it will start draining, and the ureter also will be formed by the Wolffian duct. So this is how the embryogenesis of the kidney will occur. Okay, so that's it. Then coming on to some of the pathologies with respect to, or the congenital anomalies with respect to nephron development is basically, one is Potter's sequence. Okay, please remember this Potter's sequence. Go see an image of Potter's sequence baby. Okay, so here what happens is there is bilateral agenesis of renal tissue. Okay, so there is no kidney at all. Okay, so what happens is, or else what happens is there is posterior urethral valve. Okay, so in the urethra, if there is a valve in the posterior part of it, so it will lead to a reduced renal output. Okay, so all the urine that is being formed, it will not come out at all. So please remember, it is the urine that forms the amniotic fluid. Okay, so if there is no amniotic fluid, it will lead to oligohydramnios, right? So we'll discuss more about it in obstetrics, but please remember, so if there is no amniotic fluid, it is going to go to oligohydramnios. So this is how the Potter's sequence will be. Then coming to horseshoe kidney, so it is going to be, how do we basically diagnose it is by IV pyelogram. Okay, so horseshoe kidney is basically two kidneys will be joined together in the middle. Okay, so this looks like a horseshoe, right? Horseshoe looks like this only, right? So this is how the horseshoe kidney would look like. So if we do a IV pyelogram, so it will look like a flower vase. Okay, because here the calyces and pelvis will be there. It looks like a flower vase. Okay, or handshake sign. Handshake sign are also called as Hyundai sign. Okay, so the Hyundai cars, right? So it looks like a Hyundai a car sign. Okay, so that is the thing with horseshoe kidney. Please remember the signs. Okay, then coming to duplex collecting system, the duplex collecting system meaning, so here what happens is one pelvis will be there, there is another pelvis. Okay, so this what happens is it looks like a water lily. Okay, so duplex, it will look like a lily flower. Okay, this is with respect to duplex collecting system. Then the important other points are, most common stricture that can be seen is bulbar urethra. Okay, so in bulbar urethra is where the most common stricture. We'll discuss about the parts of urethra and all in the later part of this chapter in urology. Okay, so please remember, bulbar urethra is the most common stricture occurring zone. Okay, then coming to urethral anomaly, the most common urethral anomaly will be hypospadias. Okay, meaning the urethral opening in the penis will be below. Okay, so it was supposed, the meatus was supposed to be here, but the opening will be below. Okay, below the penis. Okay, so here is how the urination will be occurring. Okay, so this should be corrected surgically. It will be done around in 6 to 18 months. Okay, in 6 to 18 month child, this hypospadias will be corrected. Okay, now after embryology, now we'll go on to the anatomy. So some of the basic anatomy is, basically we have been learning this since our first year, right? The coverings of kidney. Okay, so gross anatomy, viva and all we used to be learning, right? So a quick revision of it. So basically there is a fibrous capsule that is just outside the kidney that is covering it. Outside that there is perinephric fat. Then there will be another fascia called renal fascia. It is also called as Garrett's fascia. Okay, so then there will be paranephric fat. Okay, so two fascias and two pad of fat will be there covering the kidney. Okay, then coming to renal blood flow, some of the important points with respect to renal blood flow is left renal vein is very important. The reason is because it has a long course. One is it has a long course, and another one is it crosses the midline. Okay, so that is why it might have some immediate effects because of some other pathologies in the peritoneum. Okay, so that is why it is very important. And two additional tributaries are also coming for renal vein. Okay, so suppose this is the kidney. Okay, so this is the left kidney. Okay, so the renal vein is there, right? So true tributaries also comes. Okay, one thing is it is already long, and two tributaries are also joining. That is, one is left adrenal vein, and the other one is left gonadal vein. Okay, one from the adrenal gland it is coming, and from the gonads also it is coming. So that is why there is two tributaries also that is being formed. So that is why the risk of varicocele is very high with respect to left side. Left side varicocele is most common as compared to the right side. This is the reason. Okay, and as it is a long vein that is there, and a long neurovascular bundle it is there, so that is why in renal transplant it is the left kidney from the donor is chosen. Okay, so preferably in transplants, so left kidney is chosen because of this. Okay, there is something known as nutcracker syndrome, and the varicocele I already discussed, right? So nutcracker syndrome, where there will be severe pain because the ureter passes just this particular vein and artery. So because of the vasoconstriction, or due to overlaying of this, there will be the stenosis and all will occur, and there will be severe pain. Okay, so that is called nutcracker syndrome. Okay, then the course of ureter is very important with respect to the anatomy. So ureter flows over the iliacs. Okay, iliacus, then under the uterine artery, and also over the vas deferens. Okay, please remember this. These are the certain structures that come in contact with the ureter. Okay, iliacus, the uterine artery, and the vas deferens. Okay, then coming to some common points of obstruction are, so uretropelvic junction, the first junction, the uretropelvic junction. So most common part of obstruction, that is uretropelvic junction. Okay, then there is pelvic inlet. Okay, so in the pelvic inlet also it will be the obstruction might happen, and uretrovesical region, this is the narrowest region of the ureter. Okay, so these are all the places where the renal stone might occur. Okay, so renal stone might occur in these particular places. Okay, so this is all about ureter. So now moving on to the subtopics, that is glomerulus, right? So this is the definitive kidney, right? So glomerulus will be the definitive kidney. Here is what the function of kidney lies, right? So filtration. So some of the, you know that, right? So all the Bowman capsule and glomerulus is there, and all this PCT and endless loop is there, and then the DCT is there, then the collecting tube. Okay, so there are millions of such nephrons. Okay, so this is how a nephron would look like, though this is the glomerulus. Okay, so this is how the filtration, this is the filter. Okay, so there are some important structure with respect to glomerulus, that is GJA, that is juxtaglomerular apparatus. Okay, so there are 3 cells pertaining to juxtaglomerular apparatus. Okay, so what it contains is macula densa, extraglomerular mesangial cells, and GJ cells. Okay, juxtaglomerular cells. Okay, so this is the 3 main cells that the GJA contains. Okay, so basically what these juxtaglomerular apparatus cells, basically what do they do is, so it helps in filtration, and basically they maintain the electrolytes level. Okay, so let us see each functions. Okay, so macula densa basically senses the sodium chloride level. Okay, so let me come back to macula densa. So macula densa senses the sodium chloride level in the urine. Okay, so then what happens is extraglomerular mesangial cells. Okay, this is present in the arterioles. Okay, so this, what happens is, this basically communicates between macula densa and the juxtaglomerular cells. Okay, so now let us see what the GJ cells do. So GJ cells secrete the renin. So basically macula densa sensed the sodium chloride level in our blood. Okay, so this sends a signal through the extraglomerular mesangial cells to the GJ cells to secrete renin if there is a reduced amount of sodium chloride that is present in the blood. Okay, so this is the thing with respect to GJA apparatus. So I told you, right? So basically then RAS pathway will get activated, And then we discussed in endocrinology, right? So it is the ACTH, that ACTH is not the hormone that regulates the mineralocorticoid effect. The aldosterone effect is not regulated by the ACTH, okay, aldosterone level. It is the RAS pathway, this particular GJSLs, which tells the aldosterone to get released. Okay, so this is the pathway that aldosterone get released. Okay, so this is the thing. Okay, so please try to differentiate between the macula densa and the GJSL activity. Okay, so now let us now that we have done with all the anatomical stuff, we'll move on to a little bit of renal physiology here. So the first thing you want to know is clearance. Okay, so clearance is equal to UV by P. Okay, so UV by P. Okay, if the clearance is less than GFR, it is going to be not freely filtered. Okay, so if a substance is there and if it is getting less than GFR, so GFR is a certain value. Okay, so the normal GFR is 125 ml per minute. Okay, suppose a substance is there, and if you want to know what is the clearance that is happening with respect to kidney. So now if we'll compare the clearance with respect to the GFR, the normal GFR. What happens is, if the substance clearance is less than GFR, it means that it is not getting filtered properly, right? So then if it is greater than GFR, it means that something extra is also getting secreted other than it being in the blood vessels, right? So extra is something being secreted, so that is net tubular secretion is also there with respect to that particular substance. For example, if the clearance is almost equal to GFR, that is 125 ml per minute, it means that there is proper filtration that is happening. Okay, so the substances that are having an equal amount of clearance to GFR is inulin and cystaline. Okay, please remember, creatine is also almost equal to GFR, but there is a little bit more secretion that is happening. Okay, so that is why we will consider creatine as more than GFR, because some secretion is also happening. Okay, so from the tubules, so that is why, so creatine will be more than GFR. Okay, so this is the thing with respect to clearance. Okay, this is very, very important. Coming to effective plasma flow, it is going to be approximately equal to 625 ml. Okay, so it is the plasma flow that is happening in the glomerulus. It is going to be the 625 ml per 625 ml per minute, but it is going to be the blood flow that is happening is 1.2 liters. Okay, so out of 1.2 liter blood that is coming to the kidney, it is the 625 ml contains plasma. Okay, plasma is 625 ml. Okay, so this is the main thing. So please remember these two values. Coming to the auto regulation of the blood flow that happens in the kidney, it is by two main things. One is myogenic auto regulation, and the other one is based on the tubuloglomerular feedback. Okay, both of this will cause the afferent arteriole to constrict. Okay, so what happens is, whenever the blood flow is coming, whatever is needed, this blood auto regulation will happen through myogenic or tubuloglomerular feedback mechanism. Okay, so please note that sympathetic stimulation, that is basically norepinephrine and beta 1, okay, constricts the afferent arteriole. Okay, so this is what the norepinephrine and beta 1 does. Okay, so it basically constricts the afferent arteriole. So sympathetic basically constricts, right? So that is the thing. Then prostaglandins will dilate the afferent arteriole. Please note that it is the prostaglandin that dilates, whereas the sympathetic activation is what constricts the afferent arteriole. Okay, then it is the angiotensin 2. Okay, angiotensin 2 which constricts the efferent arteriole. Okay, so suppose this is the glomerulus, this is the afferent arteriole, and this is the efferent arteriole, right? So this is the Bowman's capsule. So this is the afferent arteriole and this is the efferent arteriole. Okay, so the efferent arteriole is controlled by the angiotensin 2. Okay, now coming to filtration, so let us see about the filtration fraction. Okay, so filtration fraction is nothing but the ratio of GFR by the renal plasma flow. So GFR we discussed, right, almost 100 to 125 ml per minute, then 625. So 625 the plasma flow, so it will come around an approximate of 20%. Okay, so 20% is the normal filtration fraction. Okay, please remember this, because in all the renal function tests and all, so this is what we are trying to elicit, okay, in any kidney injuries and all. So this is what we are trying to elicit: the filtration fraction, the clearance that is happening of a particular substance. All these things we'll be seeing. And also if there is a renal stenosis, renal artery stenosis and all, so we are gonna see for renal blood flow how much is happening, and renal plasma flow how much is happening and all, we'll be discussing. Okay, so then coming to the filtration pressure. So filtration fraction we discussed. So filtration pressure is 10 mmHg. Okay, so filtration pressure that the artery is putting on the glomerulus is basically 10 mmHg. Okay, so this is the thing with respect to the basic physiology, with respect to the physiological topic. Okay, so now let us see the functions of nephron. Okay, so each part of the nephron has a different function. So let us see each of them. Okay, we know that, right? We discussed there is a three the parts are, there will be the Bowman's capsule, which will be connected to the PCT, the proximal convoluted tubule, which will lead to the loop of Henle. Then there is the DCT, then there is collecting tubule. So this is the entire nephron. Okay, so PCT, this particular region, it reabsorbs mostly everything that is there will be reabsorbed. All the glucose, sodium, everything will get reabsorbed. Okay, so the two important things I want you guys to notice: the SGLT2 and the bicarbonate action. What happens is, so basically it is the SGLT2, the glucose transporter, the active glucose transporter, which this is what reabsorbs all the glucose from the urine. Okay, so suppose all the urine has come to the lumen, so this is what actually reabsorbs each and everything. Okay, and if the inhibitor, if there is an inhibitor that we should we should let go all the glucose, so it is the dapagliflozin and empagliflozin is what we use. Okay, so in diabetic patient, this is the target of SGLT2 inhibitor. Okay, so this is the basic target. Okay, then coming to acetazolamide, so this drug, where do we use, is basically to increase the bicarbonate excretion. Okay, so what happens is, basically all the bicarbonates are there, right? So all the bicarbonates will be reabsorbed in the PCT itself, but in certain of the cases we'll have to go for a respiratory if there is a respiratory alkalosis, we have to compensate the body to go into metabolic acidosis. So in certain of the cases, in hypoventilation, if it is a high altitude sickness and all, so we'll have to use sometimes we'll have to use bicarbonate. Okay, so so not bicarbonate, we have to reduce the alkalosis. So that is when what we'll be doing is, we'll be using acetazolamide, and we'll increase the bicarbonate excretion from the body and create a artificial acidosis level in the body. Okay, so this basically maintains the acidotic level in our body. So that is the main action of acetazolamide. So here is where in the PCT is where its action is. Okay, so then coming to descending loop of Henle, so basically all the water will be reabsorbed, making the urine concentrated. Okay, so all the water will be reabsorbed here. Okay, then coming to ascending loop, it is the sodium potassium chloride reabsorption that is happening. So what happens is, so this here the urine became concentrated as all the water was reabsorbed. Again, in the ascending lobe, what happens is, so there will be solute reabsorption, that is sodium potassium chloride, all the solids is getting reabsorbed. So this will reduce the concentration of urine, so the urine becomes dilute. Okay, so and please remember, there is no water reabsorption here, so water is not permissible through the ascending loop. Okay, then coming to the descending the DCT, that is distal convoluted tubule. So please remember, NaCl reabsorption is happening, whereas calcium is also getting reabsorbed. Okay, so there is NaCl reabsorption and calcium reabsorption. Why I'm telling you this is because there is thiazides, right? So thiazide diuretics is we use thiazide diuretics, right? So this thiazide diuretics basically acts on this sodium chloride channel only. Okay, so there will be sodium chloride block will be there from the thiazides, and all the water will also follow the sodium chloride. Okay, that is one thing, but please remember, it is the calcium channel is not affected, and calcium channel will have increased reabsorption of calcium. Okay, so it is the the channel's main function is calcium reabsorption only, but when thiazide is given, there is increased calcium reabsorption. That is why in renal stones, this is one of the best drug that can be given to prevent renal stones. Okay, so because all the calcium is reabsorbed, so there is no calcium to be formed in the urine, so that is why thiazide is used. Okay, coming to collecting duct, there are three kinds of cells. Okay, P cells, the principal cells, A cells, and the beta intercalated cells. Okay, that is A is alpha intercalated and B is beta intercalated cells. Okay, so what are the three cells and what are the functions? So basically in the principal cells there is something known as ENAC channel. We discussed this in our cardiology, right? So ANP, so atrial natriuretic peptide will act on the ENAC channel, and it will cause the sodium to get excreted. Along the sodium the water will follow, so that is what we are using in ARNI, right, for the heart failure patients, so that there is no overload in the heart. So this is what we are using. So that is the ENAC channel that is present in the P cells. Okay, so what happens is, so basically P cells will cause the sodium and water to reabsorb, but when there is a ENAC channel block by the ANP, so sodium and water reabsorption is stopped and it will be excreted out. Okay, so and also please remember there is potassium secretion that is happening in the P cells. Okay, then coming to alpha intercalated cells, it is going to be H plus secretion that is happening, and also bicarbonate reabsorption that is happening in the alpha intercalated cells. Whereas in beta intercalated cells it is the opposite. Basically bicarbonate is getting secreted and H plus is getting reabsorbed. Okay, so this is the balance that these two intercalated cells will maintain. Okay, then that is what I told you, right? ANP, that ARNI, neprisilin will inhibit the ENAC channel and help in heart failure. So this is the basic physiology and working of the nephron. Okay, so now we'll see some of the other physiologies, that is the glucose clearance that happens, right? I told you, right? So there will be 100% reabsorption in the PCT, right? All the and everything, all the glucose, sodium, everything will get reabsorbed in the PCT. But so basically when the plasma concentration is 60 to 120 milligrams per deciliter, this PCT will get this PCT will reabsorb all the glucose. But suppose if there is 200, if the blood glucose level has reached to 200, so that is when the SGLT2 cannot work anymore, and it will stop. The leftover glucose, more than 200 amount of glucose is what is there, will be passing on through the urine. Okay, so will all be excreted. Okay, so this the main excretion will be occurring at the 375 milligrams per minute. Okay, so this is the way that it is getting excreted. Okay, so the renals play, what does renals play means? So this is in first year physiology, remember, right? So renals play means that the transport maximum, the 200 milligrams per deciliter, will be reached gradually. Okay, because the different neurons have different TM, right? So all the neurons doesn't have perfectly what to 200 milligrams only, it doesn't reabsorb. What happens is some of the neurons will be at 150 only, it will stop reabsorbing glucose. Some of them will be at 250, some of them will be reabsorbing glucose. So that is why when we see the graph, it is gonna be the bent. Okay, so because this bend is, because it is not a straight line, it is going to be bent because of this renals play only, because the different neurons have different TM value. Okay, so please remember in pregnancy the TM decreases. Okay, the transport maximum decreases slightly, because to let through all the glucose that is there in the body. Okay, so that is why the transport maximum decreases in pregnant ladies. Okay, so this is a physiological phenomenon, this is not pathology. Okay, so please remember that. Now coming to the disorders with respect to nephron, so please remember Fanconi bagels, you know that, right? So bagel is just like a donut that we it is a staple that they eat in United States. Okay, so Fanconi bagel, please remember this mnemonic. So meaning the Fanconi syndrome, means there is a PCT failure. So nephron is there, okay, so PCT is there, loop of Henle is there, DCT is there, then the collecting tube is there. So each region, so if there is a defect, then it is going to be these syndromes, okay. Fanconi syndrome meaning the PCT is affected, Bartter syndrome meaning the loop V is affected, then Gitelman syndrome is DCT being affected, then the Liddle syndrome is basically the ENAC channel, the collecting tubule is affected. So let us see one by one, okay. So PCT failure meaning there is less reabsorption of any of the solids that is. So I told you, right, PCT basically reabsorbs each and everything, okay, glucose, the bicarbonate and all this is getting reabsorbed, all the sodium and all is getting reabsorbed. But if it fails, so this leads to Fanconi syndrome, okay. Then if the loop fails, the Henle's loop fails, it is going to act like a loop diuretic, right? Because see, sodium potassium chloride channel is what is there in the loop, the Henle's loop, right? So if this fails, what happens is basically inhibition of sodium chloride and sodium potassium and chloride channel will act like a loop diuretic, like furosemide and all these things, right? So it acts like a loop diuretic. Then coming to, if the DCT fails, it acts like a thiazide diuretic. Basically NaCl channel was reabsorbing everything, was getting reabsorbing, but if there is a failure here, so all will be excreted. So this is the basic action of thiazides, right? So that is the thing. So this is called as Gitelman syndrome. Then coming to Liddle syndrome, it is going to be again, so basically ENAC channel will be having increased function, okay. So one thing here, Liddle syndrome, it is not the failure of ENAC channel, it is the increased function of ENAC channel. Please note this term, okay. So please do not confuse this ENAC channel, okay. So then the other pathology with respect to nephrons is the RTA, that is renal tubular acidosis. There are three types of renal tubular acidosis, that is RTA1, RTA2 and RTA4, not 3, okay. So please remember, so here what happens is, with respect to, again we'll come back to nephron, so the PCT, loop of Henle, DCT, then the intercalated cells or the collecting tube is there. So I told you that three types of cells, that is P cells, the alpha intercalated and beta intercalated cells. So RTA1 is where the alpha intercalated cells will be failed, okay. Alpha intercalated cells failure means, so there is unable to secrete the H plus. See, alpha intercalated cells were actually having the function of secreting H plus, okay. So if the H plus is not getting secreted, what happens in the body? So all the H plus will be inside the blood only and acidosis will be forming. So this will unable to secrete the H plus. So that is why bicarbonate formation is also not there, because this is the exchange that is happening in the alpha intercalated cells. Bicarbonate is also not getting reabsorbed, whereas H plus is also not getting secreted. This will lead to acidosis, okay. So the pH of this thing is very important, because based on the pH only is what we decide what RTA is happening, okay. So yeah, pH will be more than 5.5. It will be almost a basic only, but not too much acidic as compared to RTA2. We'll come back to that, okay. So urine pH will be having more than 5.5 pH level, okay. So this is in the collecting duct is the pathology that is happening, okay. The causes being amphotericin B toxicity. Remember amphotericin B, right? The very strong the antifungal drug. So amphotericin B, which tears the fungal cell wall. So this is the thing, okay. So this also increases the calcium phosphate stones in the renal system, okay. Then coming to RTA2, here it is the PCT that is getting affected. So we discussed that is alpha intercalated cell that was affected in RTA1, whereas in RTA2 it is the PCT that is affected. So what happens is there is defective reabsorption of bicarbonate. So basically bicarbonate was supposed to be reabsorbed. So here is where the acid base balance happens. So in the PCT only it happens. So all the other things are periphery things, okay. So but the leftover things is will be having the issue, but here PCT itself is affected. So that is why the urine pH will be too much acidic, almost less than 5.5. There at least it was a little basic, okay. So bicarbonate is there in the body, but the extra bicarbonate that was needed was not being reabsorbed. So that was the issue with RTA1. Here the bicarbonate is not getting reabsorbed at all. So that is why there will be increased acidosis in the body. There is no metabolic compensation that is happening. So that is why the urine pH will be very less than 5.5 pH. Okay, so the main cause is Fanconi syndrome. We discussed, right? Fanconi syndrome. So basically there is failure of PCT. So this is the causage of RTA2. Okay, so then coming to RTA4, this also occurs in collecting duct. So RTA1 and RTA4 will be occurring in collecting duct. What happens is, this is due to the aldosterone resistance. Okay, aldosterone resistance. So these particular cells in the collecting tubule was where the aldosterone was acting on, right? So in the principal cell is where the aldosterone starts acting, but what happens is, due to aldosterone resistance, it will lead to potassium secretion. Okay, so see, basically sodium was supposed to be reabsorbed with respect to aldosterone. Suppose there is aldosterone resistance, what happens is, there is sodium that is being secreted out. Okay, sodium was supposed to be reabsorbed, but it is getting the secreting out. So it was exchanging potassium, right? So potassium was being excreted, whereas the sodium was going inside. If the channel is affected, what happens is, there will be increased potassium excretion. So this is what leads to RTA4. Okay, so with respect to this, so there is reduced ammonia excretion that is happening, because potassium is required potassium is required for sodium, for the ammonia excretion to happen. Okay, so potassium is very much required for ammonia excretion. So if too much potassium is being lost because of the secretion that is happening, so it will lead to hypokalemia, and the ammonia cannot be excreted out. This will lead to acidosis. Ammonia is very bad to our body. We had already discussed it in biochemistry. So ammonia is very bad. So now it is building up, and it will lead to acidosis, which is called RTA4, the renal tubular acidosis 4. So here the urine pH will be again less than 5.5. Here also it is very acidic because of ammonia. I told you, right, it is very toxic. Okay, this is the thing with respect to renal tubular acidosis. This is very important topic with respect to all the previous year questions. Okay, then coming on to renal pathologies. So we'll discuss the renal pathologies here. Okay, so nephrological pathologies we'll be discussing here, then we'll go on to urology. Okay, so with respect to renal pathologies, we'll send the urine routine, right? So urine routine, if we send the urine routine, we all would have seen something known as casts, right? So there will be casts there. Okay, so let us see what are the casts and what are all the diagnosis that we can do based on the casts. Okay, so there is something called as Tom Hoffel mucoprotein. Okay, so Tom Hoffel mucoprotein in all the casts. Okay, so the covering is what prevents the urinary tract infection from happening. Okay, so this Tom Hoffel mucoprotein, this is an extra point, this is an extra point, so please remember if you want to. Okay, so then coming to the different types of casts and different diagnosis that we can make. So basically, if there is a RBC cast in the urine, it means that there is a glomerular nephritis that is happening. Okay, or if even in hypertensive emergency also, this RBC casts can be seen. Okay, so meaning RBC is getting leaked out from the glomerulus. It was not supposed to happen, right? So that is getting leaked out is what it means. So if there is WBC cast, it means that the WBC is getting leaked out from the body, meaning tubulointerstitial inflammation is there and acute pyelonephritis is happening. So some inflammation or infection is happened in the glomerulus is what it means. So WBC casts. Then if there is a transplant rejection also, there will be WBC casts. Okay, then coming to granular casts, so it is the acute tubular necrosis that is happening. Okay, so acute tubular necrosis is happening. So we'll discuss ATN and all when we go down further. Okay, so acute tubular necrosis is happening. Then muddy brown granular cast is there. It means that there is rhabdomyolysis happening. Okay, so basically breakdown of muscles is what is happening. Okay, then if there is fatty casts, so then it is going to be nephrotic syndrome. I told you, right? So we'll be discussing more. So nephrotic syndrome, what happens is there is increased lipidemia. Okay, so there is increased lipid production in the body. So all this lipid will be in the blood, and through the blood all this lipid also, because there is podocyte damage that is happening, all this lipid will be coming out through this opening. Okay, so that is why fatty casts can be seen in the nephrotic syndrome. Okay, so when we see and examine, it will be Maltese cross sign. Okay, so Maltese cross. Okay, this is something known as Maltese cross. So this is how the Maltese cross would look like. So this is fatty casts. Okay, coming to waxy casts, it will be in the CKD. Okay, chronic kidney disease, and it is very, very bad prognosis, because CKD will lead to renal failure. Okay, so renal failure, what it means. Okay, so that is when we are judging them to go to dialysis. So this is how we can judge what is happening inside the body. Then there is something known as hyaline casts. These are nothing but normal casts only. So in all of us it might be there. So in dehydration or during increased exercise, these hyaline casts must be there. So if these casts are there, we'll have to ask the patient about the history, whether he was doing some exercise or he has been not drinking water, is what we should ask. Okay, in sports person, this hyaline casts might be there, and also in the diuretics users. Okay, so long term diuretic users and all, so this hyaline casts might be there. So these are some of the casts. Please go through this once again, and you will be able to identify it. Okay, then now coming to the specifics of glomerular pathologies. So these are the terms I want you guys to know. Meaning, the focal means it is the less than 50% of the glomeruli are affected. Diffuse means it is more than 50% of the glomeruli is affected. So in for example, if 10 glomerulus is there, or 10 nephrons is there, so if less than 5, that is 4 of the neurons and if nephrons is affected, then it is going to be focal. Okay, so and then if it is going to be focal, then it is, if it is 6, 7 or 8, then it is going to be diffuse. Okay, so this is the term that I want you guys to know. Then proliferative means hypercellular glomeruli is there. Then membranous means GBM thickening is there. Glomerular basement membrane thickening is there. So these are the terms before we enter the glomerular pathologies. Okay, so the two main glomerular pathologies are nephritic syndrome and nephrotic syndrome. Nephritic syndrome, the capillary endothelium damage is there by the glomerular inflammation. Okay, so so basically, see, if this is the glomerulus, so this is the glomerulus. Okay, so if it is the endothelium, okay, on the arterial side, so if the endothelium is getting damaged, it means that it is the nephritic syndrome. Okay, nephritic syndrome. Whereas if it is the Bowman's capsule side that is affected, then it is going to be nephrotic syndrome. Okay, so basically the filter is affected, meaning so it is nephrotic syndrome. Okay, nephritic is where the endothelium is getting affected. Okay, so basically all of these three layers consists of GBM. Okay, so glomerular basement membrane is what it means. So first layer is endothelium, the second is the podocytes that is there, and the third one, and then the hyaline, the heparan sulfate and all these things will be the basement membrane. Okay, so basement membrane will be formed by this. This consists of GBM. Okay, if the endothelium is affected, nephritic syndrome. If the podocyte is affected, then it is going to be nephrotic syndrome, combining with this particular GBM. Okay, then coming to nephrotic syndrome. So basically how the nephritic syndrome will present is, so endothelium is affected, so there will be RBC in the urine. Okay, so because endothelium is getting affected, so the blood can leak out, right? So blood and RBC can leak out, so that is why RBC will be in the urine. Okay, so that is why the clinical features will be hematuria, so there will be the reduced GFR and increased renin, and hypertension will be there. Okay, because there is the blood is getting leaked out. Okay, so the blood is basically getting leaked out, and there is a reduced amount of blood that is coming to the kidney. Okay, so that is why what the kidney does is, so because of some issue, I'm not getting blood, so let me increase the pressure in it. So that is why all the sodium will get starting reabsorbed. So from the RAS pathway activation, so all the sodium and water gets reabsorbed and increases the hypertension or BP. So that is why in nephritic syndrome there will be hypertension. Okay, this is the difference between nephritic and nephrotic syndrome. Here there is no hypertension. Okay, with respect to nephrotic syndrome. Okay, So here is where the podocytes are damaged, okay, because of some various causes. We'll discuss all the causes, okay. So it will lead to impaired charge barrier. So right here the heparin sulfate was supposed to give the negative charge, okay. So negative charge the heparin sulfate is giving, whereas the podocyte is also giving negative charge, okay. So all the protein, that is albumin and all, are also carrying negative charge. So that is why negative meaning, so it will repel out. So physics, basic physics, right, negative will repel the sodium. But if there is a loss of this negative charge in the GBM itself, so all the negative albumin can leak out. So because there is no repelling force, so that is the basic pathogenesis behind nephrotic syndrome, okay. So the clinical features will be proteinuria, because all the protein, the albumin and all is getting leaked out. So proteinuria of more than 3.5 grams per deciliter. See, it was supposed to be 0, okay. So this is 0 was supposed to be in normal people. If the protein is getting leaked out, so there will be edema, because albumin is what maintains the oncotic pressure, right? So if there is no albumin, how will the fluid be inside the blood vessel? So all the fluids will get leaked out, okay. So because of the reduced osmotic pressure, okay. So then coming to, there will be hypoproteinemia, because all the protein is getting leaked out, and there also will be hypercholesterolemia, because see, liver, so liver basically produces albumin, okay. So albumin. So now because there is a reduced albumin in the blood, so this starts increasing the albumin production. Along with increasing the albumin production, there is also fatty acid synthesis increase that is happening in the liver, okay. So this is where the fatty acid synthesis also happens, right, in the liver. So it is increasing all and everything, all the functions of the liver, okay. So along with albumin increase, so it will also increase the fatty acids, which will lead to hypercholesterolemia. So this is the basic pathogenesis behind nephritic syndrome and nephrotic syndrome. So now diving deep into the specifics of nephritic syndrome and nephrotic syndrome. So there are various pathologies that can happen in nephritic syndrome and nephrotic syndrome. So let us see one by one, okay. Okay, so to begin with, so PSGN, okay. So PSGN is post streptococcus glomerulonephritis. What happens is, suppose there is a streptococcal infection that is happening. For example, let us take pharyngitis or something. After 2 to 3 weeks, suddenly if the patient or the kid starts or comes to you, presents to you with hematuria, and you will a patient comes to you with hematuria. Now you are asking the history. So in previous history, on the recent history, so the patient will tell you, so the patient had contacted, the fever was there, pharyngitis was there 2 to 3 weeks ago, okay. So now you can go and think that, oh, okay, so he might be having PSGN, okay. So immunofluorescence is what is important in all of this. So that is the difference they are gonna ask, okay. So immunofluorescence looks like a starry sky, okay. So please go and look at all the immunofluorescence. So there has been best given in first aid textbook, okay. So in first aid it has been best given. So please go through all the immunofluorescence, okay. So this is how we can diagnose PSGN. Then coming to IgA nephropathy, okay. So this is the most common type of nephritic syndrome, okay. If there is IgA nephropathy, so basically 2 to 3 days post upper respiratory tract infection. See here, it was 2 to 3 weeks after the infection that the patient came in. But here, if the patient presents to you just within 2 to 3 days, it is going to be IgA nephropathy. So that is how we can diagnose. And also the patient will be having an history of IgA vasculitis, okay. So all the types of vasculitis might be there. So mainly Burger's disease. So this is a type of vasculitis, right? So this might complicate to IgA nephropathy, okay. So in immunofluorescence, there will be basically IgA deposition will be there in the mesangium, basically mesangial cells, the IgA deposition will be there. And coming to histology, so there will be mesangial proliferation, okay. So mesangial proliferation will be there with respect to histology. Then coming to RPGN, that is rapid progressive glomerulonephritis. Here the progression will be rapid, okay. So rapidly the disease progression will be there. So there are 3 kinds of RPGN. One is based on the good pasture syndrome, okay. Then the other one is immunocomplex deposition, and another one is POWSI, okay. So So in Goodpasture syndrome, so the syndrome, we know that, right? So the alpha 3 subunit will be affected. Okay, so the alpha 3 collagen will be affected. Here the immunofluorescence will be linear. Okay, immunofluorescence will be linear. Okay, so the reason is all the other things that we are going to discuss will be granular. Okay, so all the other pathologies will be granular, whereas RPGN will be linear. Okay, please remember that. Okay, so then coming to histopathology, so crescent sign. Okay, so the crescent sign is very pathognomic. Okay, if you see a glomerulus, so there will be a there will be a crescent sign that we can make out. Okay, so the crescent is half moon shaped, glomerulus is what we can make out. Okay, so crescent sign, this is very pathognomic, please go see it. Okay, see, Goodpasture syndrome means it is affecting both lungs and the kidney. Okay, if both lungs and the kidney is affected, it is Goodpasture syndrome. So now we diagnosed the PSGN based on how the patient presented after the infection. Now 2 to 3 days it was IgA nephropathy. So just by the history itself, how can we diagnose RPGN is, so the patient will be telling both the lung and renal pathology symptoms. Okay, so that is how we can think that, oh okay, he might be having RPGN, that is Goodpasture syndrome might be there. Okay, so this is the thing. Then coming to the immunocomplex type of immunocomplex deposition of RPGN, it will be granular. Okay, so granular, please note that the POWSY type of RPGN will be having no immunofluorescence. Okay, so please remember this is very important. Where is there is no immunofluorescence, meaning that is POWSY type of RPGN. Coming to Alport syndrome, this is one more type of can't see, can't pee, and can't hear a B. Whereas you remember the orthopedics where we discussed about Reiter syndrome, where it was can't see, can't pee, can't move my knee. It was in Reiter syndrome. It is the Alport syndrome where it can be can't see, can't pee, and can't hear a B. Okay. Here there is hereditary alpha 5 subunit that is affected. Here in Goodpasture it was alpha 3, whereas in the RPGN it is, I mean, if in Alport syndrome it is going to be alpha 5 that is being affected. Here it is a type 4 collagen that is the defect here. So again I told you, right? So until RPGN it was the linear deposition. Here it is going to be granular. Okay, granular immunofluorescence. Okay, and the histopathology would look like basket weave will be there. Okay. Then coming to lupus nephritis, diffuse proliferation will be there. Okay, so diffuse proliferation glomerulonephritis is the name actually for lupus nephritis. So here basically because of SLE. Okay, so all the complements will go and get deposited in the glomerulus or the endothelium. This endothelium will get damaged. Okay, because of IgM, IgG, C3, C1, CQ, all these complements will go and get deposited in the endothelium and will destroy the endothelium. Okay, so here also the immunofluorescence will be granular. Okay, so when we take a histopathology, it is going to look like a wire looping of capillaries. Okay, then coming to MPGN, membranoproliferative glomerulonephritis, there are two types, type 1 and type 2. Okay, so type 1, if it is happening, it is because of HBV or HCV, hepatitis B or hepatitis C, that is happening. Or if it is a type 3, it is going to be complement 3 nephritis factor. Okay, so this is the thing with MPGN. So here also it is going to be granular. Okay, so if we take a histopathology, it looks like a tram track appearance on H&E. Okay, so if we take a H&E sample, H&E histopathology, it is gonna look like a tram track. So basically just by the history itself we can diagnose any of this, right? So that is the thing with nephritic syndrome. So now coming to nephrotic syndrome, here also based on history itself we can diagnose what kind of pathology is happening. So the nephritic syndrome etiologies are MCD, that is that is the most common type. Most common type is FSGS. Okay, so please remember FSGS is the most common type. There it was IgA nephropathy, that was the most common type. Here MCD, the minimal change disease is basically because of idiopathic. Okay, idiopathic, there is no causative agent that that is there. There is no this mainly occurs in very pediatric patients. Okay, so very less than 1 year, or between 1 year to 2 year patients, this MCD might happen. So here there is perfect podocyte effacement. Okay, podocytes, I told you, right, the 3 layers of GBM. Here the middle layer, that is the podocyte, is getting affected, and we can see this in the electron microscope. Okay, they will be giving in question, light microscope has podocyte. No, it is the electron microscope where we can identify podocyte. Okay, effacement. Okay, then coming to FSGS, focal segmental glomerulosclerosis. I told you, right, focal meaning it is going to be the less than 50% of the glomerulus is being affected. Okay, so primary will be idiopathic, just like MCD, but secondary will be associated with HIV, sickle cell anemia, and chronic heroin users. Okay, so FSGS might occur. So here, if we take a histopathology, so here in nephrotic syndrome, so immunofluorescence is not taken. It is the histopathology based the diagnosis that we do. So that is why if we are suspecting a case of nephrotic syndrome, we'll take the biopsy. So biopsy is done for nephrotic syndrome. Long-term nephrotic syndrome cases, we'll do a biopsy. Okay, so in histopathology, the FSGS would look like something like this. Segmental sclerosis will be there. Okay, so this is the thing with FSGS. Coming to membranous nephropathy, there are two types. One is primary and secondary. So please remember this. It's very important. The primary is antiphospholipid A2. Because of antiphospholipid A2, if it is happening, it is going to be primary. Whereas the HBV, HCV, just like we discussed in MPGN, right? So the secondary, if it is there, it is going to be HBV, HCV, SLE. All these things might complicate. Okay, so disease related, so it is going to be secondary, whereas antiphospholipase A2, it is the defect, then it is going to be primary. Okay, so if we take a histopathology, so there will be GBM thickening, spike and dome appearance. Okay, so this is very pathognomic. So we can see a thick GBM. Okay, so thick GBM will be there when we take a look at it. Okay, so this is how the GBM would look like. Then coming to amyloidosis, so basically deposition of amyloid proteins is what is happening in the glomerulus. So there is apple green bisfringence. This is very pathognomic. So please go see an image based thing with respect to amyloidosis. Okay, so there is basically mesangial expansion that is happening, okay, in amyloidosis. Coming to diabetic glomerulonephropathy, so this is what the most common that we see, right, with everyone. So nephropathy is happening, so meaning diabetic nephrotic syndrome is happening. Okay, so what happens is basically there is hyperglycemia in diabetic patients, right? So what happens is there is glycation of all the molecules around the glomerulus. So there will be structural damage that will be happening because of all the glucose deposition. So there is increased glucose, meaning there will be increased mesangial proliferation, because the cell is getting too much glucose. It acts like a growth factor, and there is too much mesangial proliferation, which will lead to compression. Okay, so which will lead to the compression of the arterioles. Okay, so which will lead to the compression of the arterioles. So that is when there will be increased GFR that is happening. Okay, because there will be RAS activation. So RAS activation will cause increased GFR. Increased GFR meaning, so there will be increased protein loss, because the podocyte, everything is damaged. So all this will lead to protein loss, because there is increased GFR also that is there. So this will basically push everything out. Okay, so that is the basic pathogenesis. And also there is the sodium glucose absorption in the PCT that is happening. So that is why, so increased glucose is there, so there is increased sodium absorption is also happening. So there is less sodium that is reaching the macula. So that is where the RAS activates. Okay, so here also again, so there are two kinds of pathogenesis, because of the glycation, and other one is because of the increased sodium glucose absorption. So this is the basic pathogenesis behind diabetic nephropathy. So if I take a histopathological slide, then there is something called as Kimmel-Stein-Wilson lesion. So this is what the Kimmel-Stein-Wilson lesion would look like. This is a very pathognomic. Please go see an image of it. Okay, this is all and everything you need to know with respect to all the glomerular pathologies. Okay, so now we'll dive into the major thing, that is acute kidney injury and the chronic kidney injury. Okay, so there are three kinds of acute kidney injury which can happen pre-renal, before the before coming to kidney itself, there might be some issue, or the renal issue there might be there, or the post renal issue might be there. Okay, so let us say one by one. Okay, so pre renal meaning there might be some issue with blood coming into the renal system. So that is why the kidney will be having a less blood flow and lead to kidney injury. Or if it is a renal, so it is going to be inside the kidney, there's some issue with the filtration that is happening, so that might have led to the injury of the kidney. And if there is a post renal, meaning there is some obstruction that is happening, all the filtered thing will be in the kidney because it is not getting excreted out. So that is why the kidney injury might have happened. So these are the acute causes of kidney injury. Okay, so that is why the name acute kidney injury. Okay, so how do we diagnose pre-renal, renal from post-renal is, so in pre-renal, because of hypovolemia, so basically blood is not coming, not enough blood is there to reach kidney. When does it happen? In left ventricular failure and all, the blood cannot reach the kidney, right? So basically when there is reduced cardiac output. So this is one of the major cause of pre-renal kidney injury. Okay, so here because of there is no proper amount of blood that is coming in, so there is reduced blood flow, which will also reduce the glomerular filtration rate, which increases the RAS activation. Okay, and increases the sodium and water reabsorption from the urine. Okay, so sodium reabsorption and water reabsorption is increased to increase the GFR. Okay, so this is the RAS activation that is causing it. So that is why there is reduced sodium. Okay, so reduced sodium in the urine because everything is getting reabsorbed. So the value is less than 20, it will be there. Okay, so urine sodium will be less than 20. Please remember this, because this is what we will use in our clinical practice also to differentiate between the type of AKI that is happening in that person. Okay, so this is the thing. Okay, then the fractional sodium excretion will be less than 1% because everything is getting reabsorbed. So this is also one extra thing. And please remember the serum BUN to creatine ratio, that is blood urea nitrogen to creatine ratio, will be higher than 20. Okay, the reason is, see, urea is also getting reabsorbed from our kidney. When there is increased sodium and water reabsorption, along with the urea is also getting properly reabsorbed. So see, proper kidney function means there is proper urea reabsorption also. Not all the urea will be getting excreted out. Reason being, it should maintain the medullary concentration. Okay, so in the Henle's lobe there is urea that is maintaining the concentration. Okay, so medullary concentration should be maintained by urea only. So that is why all the urea will also be reabsorbed. Okay, so if there is no proper urea reabsorption, so there urea is not very much toxic as compared to ammonia. Please remember, ammonia is toxic, not urea. Okay, so blood contains a certain amount of blood urea, which balances the basic medullary concentration in the renal system. Okay, so that is why there is no renal issue or no renal filtration issue that is happening in the pre-renal AKI. So that is why there is normal reabsorption that is happening. So that is why a serum BUN to creatine ratio will be higher than 20. Okay, then coming to renal AKI, so it happens because of two main reasons, that is acute interstitial nephritis or acute tubular necrosis that is happened. Okay, so we'll talk more about this down. Okay, so basically what happens is, in both of this there is debris which is obstructing the tubule for proper function of its tubule, right? So debris are not letting the proper filtration. So this is where the pathology comes in, so which will lead to increased sodium excretion because nothing is getting reabsorbed, all the debris are not allowing it to getting filtered, and the fractional excretion of sodium is higher than 2%, where it was less than 1% in pre-renal. Okay, and the blood urea nitrogen is also getting affected, so that is why all the urea is also getting excreted. So that is why it will be less than 15 in the ratio will be there. Okay, so this is with respect to renal AKI. Coming to post-renal, I told you, right? So there will be some obstruction here post-renally. So that is a stone or somewhere here down. It is going to be BPH, benign. There will be BPH. Okay, so the prostate gland will be hypertrophied. Okay, so then so basically there will be bilateral outflow obstruction might be there. Okay, because of BPH. Okay. This is the thing with respect to post-renal. Okay. Now, with respect to renal AKI, I told you, right, there are two causes. That is acute interstitial nephritis and acute tubular necrosis. So, we will see one by one. Acute interstitial nephritis meaning it is because of drug-induced hypersensitivity reaction. Some drug would have caused hypersensitivity reaction, which would have led to interstitial inflammation. Okay, in the glomerulus, okay, which will lead to pyuria and azotemia. Okay, pyuria meaning there is WBC that is there in the that is there, that is the debris that is causing the problem here. So WBC casts and all will be there, so that is causing the improper fertilization to occur in the renal system. Okay, so that is the acute interstitial nephritis. Coming to acute tubular necrosis, what happens is, so basically some ischemia would have happened or nephrotoxic substance, for example contrasts, the IV contrasts and all that we use, CT contrast and all will always be removed through kidney only, right? So if some substance that is contrast has caused the insult to the glomerulus, it will be leading to AKI. Okay, so please remember, if it is less than 24 to 48 hours, within less than 2 days of us giving a contrast, this AKI is happening, so that means that it is the contrast that caused the AKI. Okay, please remember that. Okay, so there are 3 stages of acute tubular necrosis. It is self-resolving actually, basically. So there is a initiating phase, then the maintenance phase and the recovery phase. So it will resolve on its own. Okay, so basically we need not do anything, just the supportive therapy. So basically management is good prognosis, it will resolve on its own. And please remember, so that is why if there is a renal insult that might happen because of contrast, we will be adding N-acetylcysteine before giving the contrast. Okay, so this is everything with respect to acute tubular necrosis. Then the biomarkers with respect to acute kidney injury is, please remember this is a previous year question, KIM1, NGAL, IL-18 and cystatin. These are the biomarkers, just like cardiac biomarkers that we had seen in cardiology, right, with respect to MI, that is CKMB, troponin, all these things. Okay, so in the same way, KIM1, NGAL and interleukins, all these things can be the biomarkers of acute kidney injury. So now, if the acute kidney injury progresses to being chronic, so let us see how it happens. Okay, so when do we tell it is a chronic kidney disease? Is when there is a renal dysfunction for more than 3 months is happening. Okay, if the renal dysfunction is more than 3 months and the renal function is not properly happening, it will lead to chronic kidney disease. What is the criteria that we use is basically based on the GFR, okay, and the presentation that it gives. So GFR, if it is less than 60 ml per minute per 173 meter square, then we are gonna diagnose it as CKD. Okay, so a person with the CKD, how we diagnose is based on GFR. Okay, the presentation will be proteinuria will be there because there is no the protein reabsorption is not happening, or everything is getting leaked out, and hematuria, then a structural abnormality will be there in the kidney. Okay, so this is how we can diagnose CKD. So there are stages of GFR, and based on the stages only we manage the patient. Okay, so this stages is based on the GFR. Okay, so glomerular filtration rate is what we take to decide what stage the CKD is in. Okay, if it is more, so this is basically table of 15. Okay, 15, 30, 45, 60 in that way. Okay, so let us see one by one. If it is more than 90, GFR more than 90, normal is, I told you, right, 100 to 125 will be the normal GFR. If it is 90, we are going to take it as CKD 1, stage 1, and is 60 to 9 is 89, stage 2, then 30 to 60, it is going to be stage 3, and 15 to 30 is stage 4, and stage, if it is less than 15 GFR, so basically nothing is getting filtered out, so this will be failure. Renal failure is what we take. Okay, then in the stage 3 and stage 4 is where the complications starts appearing. Okay, with respect to CKD. Okay, in the patient, what all we can see is there is increased anion gap, metabolic acidosis, electrolemia, anemia of chronic diseases, then uremic encephalopathy, because everything is, all the toxins are staying inside the body only, so nothing is getting excreted. So then there will be fluid overload. Okay, so this might lead to congestive heart failure, and this is the leading cause of death in CKD patients. Okay, so this is the thing with respect to CKD. So now now that we know the stages, how do we manage? So basically we'll treat the cause that is causing the CKD, and it is basically supportive treatment that we give. Okay, and also we please note that we should maintain the BP, and ACE and ARBs are the best things that we can give for renal, because it will directly act on the RAS pathway, right? So RAS is what is so based on RAS pathway is how the hypertension is happening because of the increased GFR that so the kidney is trying to increase the GFR, and all this nonsense is happening because of that only. So once we use these blockers, so we can somehow try to do the antihypertensive action, and will somehow try to reduce the complications caused by CKD. Okay, so this is the thing. Then there is renal replacement therapy, also called as dialysis. Okay, so we'll use something known as AEIOU to decide the dialysis. Okay, so suppose if there is a AKI patient, also acute kidney injury patient, also sometimes we'll need the dialysis. And here I told you, right? So with respect to GFR, we'll decide what management. So suppose there is less than 15 has gone for failure, now we'll have to use dialysis. So this is how we choose dialysis. Okay, so based on the acidosis status, AEIOU, the ovals. Okay, remember, right? So AEIOU, then E for electrolemia, then intoxication and overload and uremia. So if these symptoms, any of the symptoms is there or any of the feature is there, we'll go for dialysis. Okay, so this is how we do the management of CKD patients. Okay, so this is all and everything you need to know with respect to nephrology. Okay, so now we'll move on to the second part of this video, that is urology. Okay, so starting with urinary tract infections. So at each different region, so let us see how the infections might happen. So starting from urethra, then the bladder. Okay, so then the this is cystitis, then coming to the pyelonephritis. Okay, so let us see what all happens. Okay, so in urethritis, it is the urethra that is being affected. So here, if the urethritis is there, then it is going to be burning urination symptom will be there. Then coming to, there will be some discharge that will be happening. Okay, so some whitish discharge or reddish discharge might be there. Okay, then coming to cystitis, if it is the bladder that is involved, so there will be increased urgency and frequency of urine, and there will also be suprapubic pain that will be there. Okay, so this is how the presentation will be there. Then coming to pyelonephritis, basically the kidney is involved. So here there will be fever, flank pain, and vomiting and tenderness will be there in that particular quadrant. Okay, so this is how the all the urinary tracts infections will present with. Okay, there is something called as interstitial cystitis. Okay, which mimics the cystitis, but there is no bacteria. Okay, so this is also painful. The suprapubic pain will be there just like cystitis, but there will be no culture, there will be no bacteria. Okay, this is called as interstitial cystitis. Okay, or also known as Hunner ulcer. Okay, that's it. Then coming to the organisms that are involved with the infections or UTI. So the most common organism with the UTI is E. coli. So the other organisms are, if there is a hospital acquired UTI, it is going to be Klebsiella most commonly. If it is a kidney stone that is causing the UTI, most commonly it will be the Proteus mirabilis. Then sexually active women, please note this down, it will be the Staphylococcus saprophyticus. Okay, Staphylococcus saprophyticus in sexually active women. Then coming to nosocomial infections, it is going to be the Enterococcus fecalis. Okay, then if it is a catheter based UTI that is happening, then it is going to be Pseudomonas aeruginosa. So these are all the important organisms. Please go through this. Okay, then coming to management of UTI, so based on the complications is how we manage the patient. If it is an uncomplicated patient, it is going to be OPD basis we are going to give. So it is the nitrofurantoin is what we give. Okay, so nitrofurantoin is what we give. Okay, please note, it is not the norfloxacin. So norfloxacin is not being given, it is the nitrofurantoin. It is a OPD basis treatment that we do. Okay, so nitrofurantoin has a side effect which will be pulmonary fibrosis. Please note this down. Okay, Then coming to complicated cases of UTI, what we'll do is we'll give third generation cephalosporin, that is ciprofloxacin, moxifloxacin and ceftriaxone. IV ceftriaxone treatment also can be done with respect to complicated case. So we'll basically, this is the inpatient management, IP management, and we'll be treating with IV drugs. Okay. Then coming to pyelonephritis, we'll be giving IV ceftriaxone. Okay, so remember this. In pregnant women, we can't give any of these drugs, so that is why we'll go for amoxiclav. So because all these drugs can be, if nitrofurantoin, ciprofloxacin and all, so might be teratogenic, so it can, the safest drug will be amoxiclav that we can give with respect to pregnant women. Okay, so because fluoroquinolones and all is teratogenic, right? So that is why we'll go for amoxiclav, the safer option with respect to pregnancy. Then coming to the other important topic with respect to urology is renal stones, right? So renal stones, so we'll be dividing based on the composition of renal stone. So if it is a calcium renal stone, it is going to be two types. Okay, calcium oxalate and calcium phosphate. Okay, so please remember all the type of structure that it has. Okay, calcium oxalate will be envelope shaped and phosphate will be wedge shaped. Okay, envelope meaning, so it will look like an envelope. Okay, so this is how the oxalate, calcium oxalate will look like. Then coming to management, it is going to be thiazides that we give, because thiazides, I told you, right? So thiazide helps in calcium reabsorption, so there will be lesser excretion of calcium that will be there. So that is why we'll give calcium thiazide diuretics. Okay, then coming to struveite stone, the staghorn stone, you know that, right? So if this is the kidney and this is the pelvis, so entire pelvis will be affected by the struveite stone. So this looks like a staghorn. Okay, so this is how a staghorn stone would look like. So what we the thing is, the composition is, so ammonium, magnesium phosphate can be the composition. Okay, and also please note, if there is a UTI, it is going to be the Proteus mirabilis and Klebsiella, the most common organism we discussed above, right? So this is the most common organism that might be causing this, and the appearance will be coffin lid like. Okay, so if it is a coffin, okay, this is a coffin and this is how it would look like. Okay, so the coffin lid. Okay, so how do we manage? So basically entire pelvis is involved here, so that is why we are going to do percutaneous nephrolithotomy and then treat the infection with so Proteus infection might be there, so that is why we'll be treating the infection. Okay, then coming to the other stone, that is uric acid stone. Okay, so it will be radiolucent. Okay, so radiolucent is the, all the other are radio opaque, whereas this is a radiolucent stone. That is why it is very difficult to identify through the scans. Okay, then the shape will be the rhomboid shape. Okay, rhomboid shape will be there with respect to uric acid stone. Okay, then coming to management, it is going to be, basically we'll alkalize the urine. Okay, so this is how we will manage the uric acid stone. Okay, then you know that, right? So allopurinol basically reduces the uric acid level, so that is why we'll also add allopurinol as the adjacent along with the treatment. Okay, then coming to cystine stone, it is going to be hexagonal in shape, cystine stone. Okay, this is very painful stone. Okay, so hexagonal in shape. Okay, then the management will be, so basically again just like that one, it will also alkalize the urine, and also if not possible, then we'll go for ESWL. Okay, so that is basically extracorporeal corporeal sound wave lithotripsy. We'll use the sound waves and we'll use the C-arm and all, right? So if you have gone to urology department, you would have seen this. So basically so urology, the stone management will be doing extracorporeal sound wave lithotripsy, and then destroy so break down the stone, and then we'll let the stone to pass through. Okay, so now let us see the specific managements with respect to renal calculi and ureteric calculi. Okay, suppose if the stone is in the kidney, how we manage, and how we manage a ureteric calculi. So renal calculi, so if it is less than 0.5 centimeter, what we are going to do is, we are going to give an analgesic for the pain, and we'll give alpha blocker and calcium channel blocker. This will basically relax the ureter and let the stone pass through. Okay, so if this is less than 0.5. Now if it is 0.6 to 1.5 centimeter, if it is a renal calculi, we are going to go for ESWL. Whereas if it is more than 2 centimeter, then we are going to go for PCNL. Okay, so then after that we are going to place a DJ stent. So basically DJ stent is a tube, so which will put, okay, from the urethra we'll be putting inside, and we'll let the digestant stay here, and then we'll let it allow into the bladder. Okay, so from here, so after this procedure we'll place a digestant, so through which the stone will pass through and come down to bladder. Okay, so this is what we do, okay, with respect to renal calculi. Now coming to ureteric calculi. So basically the investigation of choice is NCCT. Okay, so non-contrast CT is what we use. So if it is less than 0.5, so basically again the same thing. So alpha blocker, calcium channel blocker, and an analgesic will give. So same with respect to renal calculi also, and also will alkalize the urine. Okay. Then coming to if it is more than 0.6, so if it is a non-impacted case, then we are gonna go for URS, that is retrograde. We'll go and we'll remove the stone. If it is an impacted, then we'll go for ureterolithotomy. So first we'll go and break the stone, and then we'll retrieve it. Okay, so this is the basic difference between how we can manage renal calculi and ureteric calculi. Okay, so this is all and everything you need to know with respect to renal stones. Okay. So now moving on to the tumors of kidney. This has been very important topic. Okay, so we'll discuss about the tumors of kidney, and tumors of bladder is what is very important. Okay, so tumors of kidney, there are two types, that is benign and malignant. Okay, so benign is not much of an importance. The malignant, that is the adenocarcinoma, the renal cell carcinoma, is what is very, very important. Okay. Then there is something called as transitional cell carcinoma and the Wilms tumor. Okay, so we'll discuss about it. So first we'll go for adenocarcinoma, that is the renal cell carcinoma. It is also known as Gravit's tumor. Okay, so here in adults, that is 50 to 70 years age, is what the highest risk of renal cell carcinoma is. So there is an increased risk of RCC with respect to smoking and also genetics. Okay, so as it is a malignant carcinoma, it's gonna spread by hematogenous pathway. Then there is 4 types of classification with respect to RCC, that is clear cell, papillary, chromophobe, and the collecting duct renal cell carcinoma. So based on each region that is involved with respect to nephron is how we have divided it. Okay, so if the PCT is involved, it is going to be clear cell carcinoma. If it is DCT, it is going to be papillary carcinoma. If it is a collecting tube, it is going to be the chromophobe and the collecting duct carcinoma, RCC. Okay, so in PCT, as the name suggests, the clear cell, so basically the clear cytoplasm can be seen. In papillary, there will be papillary arrangement. So papillary, you know that, right? Papillas. Okay, this is how the arrangement will be. Then in chromophobe, there will be perinuclear halo will be there, and collecting duct, this is a worst prognosis. There will be dysplasia. Okay, then so some of the important points about this are, so VHL gene, that is the von Hippel-Lindau gene, is involved in clear cell carcinoma. Trisomy 7 with respect to papillary carcinoma. Monosomy can cause chromophobe, and here, as I told you, collecting duct has the worst prognosis. Okay, so this is the basic classification of the renal cell carcinoma. Coming to the clinical features of renal cell carcinoma, so basically this is a triad. Okay, so triad is very, very important. So how is gonna be the patient presents to you with is gross hematuria will be there, flank pain will be there, and the palpable abdominal mass will be there. See, based on hematuria and flank pain, we will be thinking either it is a glomerular nephritis or probably it is a renal stone that might have happened. So that is when we will do some CT. Okay, so before doing CT, we'll try to palpate, we'll do the examination, right? So that is when we do the palpation of the abdomen, there might be a mass. Okay, so that is when we will differentially diagnose it as renal cell carcinoma. Okay, so now basically it will be in the grossly in the poles of the kidney basically. Okay, and it will be unilateral. Okay, so that is how you can differentially diagnose it from other things. Okay, then coming to the management, so all the basic routines and all will be sent with respect to blood and urine routines will be sent, and this is the CT abdomen is what is the gold standard. So that is what I told you, right? So the differential diagnosis is there. So now what we'll do, we'll go for USG and then CT. So CT abdomen is the gold standard, how we can predict it is RCC. Okay, so then the surgical management is the mainstay of management. So we'll manage based on the stages of it. Okay, so if it is a localized first two stages, so basically it will be localized. Okay, so first two stages we are gonna do partial or radical nephrectomy. Then if it is a locally advanced, so third stage it is going to be radical nephrectomy plus adjuvant chemotherapy is what we are going to give. So if it is metastatic, it is already metastasized and we cannot do any surgery, so that is when we go for immunotherapy and imatinib. Okay, so imatinib, please remember it. Okay, so this is the basic management with respect to renal cell carcinoma. Okay, so now coming to Wilms tumor, I told you, right? So other malignant tumor. So the Wilms tumor will be more in male than female. Okay, Wilms tumor will always be in kids. Okay, so it is the 1 to 6 year old kids that will be most commonly affected. It is the WT1, the Wilms tumor 1 gene, which is affected. If the mutation is there, then basically it is involving the entire kidney and the so basically the kid will be, when we do the examination, the palpable abdominal mass will be there. Okay, painless palpable abdominal mass will be there. So that is how we'll diagnose Wilms tumor, and we'll do the investigations of VMA. Okay, investigation will be VMA, we'll be testing for it, and so if it comes out, then we'll decide it as Wilms tumor and then do the management. Okay, so basically resection of the entire kidney is what we do. Okay, so then coming to, now we are done with the tumors of kidney. Now we'll go to tumors of bladder. Okay, so you know that, right? The transitional cell is what is the squamous cell of bladder and all the urinary tract. Okay, so please go through the histology slide of the transitional cell, because they have been asking repeatedly with respect to what is the cell, or what is the tissue that is being formed for forming the ureter or say the bladder and all these things. So that is why please go and take a look at the histological slide. Then transitional cell is the most common type of tumor that occurs in bladder. So it is associated with smoking and phenacetin. Okay, so then aromatic amines, then cyclophosphomides. Okay, so this is what it is associated with. So mostly smoking. Okay, so smoking causes this transitional carcinoma. Sorry. Okay, then there is a depth of invasion is the prognosis of it. So the how we prognosis this transitional carcinoma is based on how much depth the cancer has been going into. Okay, then the management is basically intravesical BCG therapy is what we give. Okay, so this is the thing. Then coming to squamous cell carcinoma, this is very, very important. Please note that schistosoma hematobium. Okay, remember, right? Schistosoma hematobium will be causing the squamous cell carcinoma. Then if it is the schistosoma mansoni, it is gonna be the cholangiocarcinoma. We discussed in hepatology, right? Cholangiocarcinoma by schistosoma mansoni, whereas schistosoma hematobium will be causing squamous cell carcinoma. Please remember this. Also, there will be a risk of chronic cystitis and stones, which might lead to squamous cell carcinoma. Okay, so basically chronic cystitis will lead to squamous cell metaplasia, which will lead to carcinoma of bladder. Okay, so the clinical features will be painless hematuria will be there. Okay, then how the management is, basically Nd:YAG laser is what we use. Okay, so there it was BCG therapy intravesical, here it is the Nd:YAG laser is how we manage the squamous cell carcinoma. Okay, so now coming to one of the important topic, that is the genitourinary trauma. Okay, so in genitourinary trauma, so there are different levels at the in the genitourinary system where the trauma might happen, and each of them present in a different way. Okay, so let us see how it is presenting and how we will manage them. Okay, so this is very, very important topic. Okay, so let us divide the genitourinary system as renal, then the bladder is there, then the urethra. Okay, so let us see at each level what happens. Okay, if it is a renal trauma that has happened, we'll see how we diagnose it is based on whether the patient is stable or not. Okay, so whether the patient is stable or unstable. If the patient is stable, we are going to go for CT urography, or CECT is what we are going to do, and diagnose what is the type of injury and what stage the injuries happened. Suppose if the patient is unstable with the vitals, what we are going to do is there is a single shot IV ureterogram that we are going to do and see how the kidney would look like. Okay, so this is how we will be doing the investigation. And you know that, right? We had discussed in general surgery based on the stages, that is a 1 and 2 stage we are going to just observe the patient, and 3 and 4 we are going to go for if it is shattered, I mean 3, 4, 5, if it is shattered and all, we'll be going for a resection of the entire nephrectomy, or in spleen also we did the splenectomy, right? So here also it is in the same way, based on the stages or the grades of trauma we are going to manage. Okay, so now coming to bladder, if now the kidney is done, now we'll go for bladder. If the bladder is affected, so the investigation we'll do is CT cystograph. Okay, so to see where exactly the leakage is happening from the bladder. Okay, so this is how we'll diagnose or investigate the two traumas. Okay, so please remember, so in renal and the bladder trauma, it is going to be hematuria. Okay, hematuria will be the presentation with respect to this. Whereas in urethral trauma, if the trauma is in the urethra, it is going to be blood at the meatus. Okay, blood at the meatus is what the presentation will be. Okay, so what do we do for the investigation for urethral trauma is basically retrograde. We are going to go retrograde urethrography and see where the leakage or the trauma has happened. Okay, so this is how the genitourinary trauma can be divided. Okay, so now let us see one by one. Okay, so bladder rupture can be extraperitoneal or intraperitoneal rupture. Okay, so if it is a penetrating trauma or a open book pelvis fracture has happened, so it will lead to extraperitoneal bladder rupture, which the clinical feature will be pelvic urinoma, because all the urine that is present in the bladder will leak out into the pelvis. So this is how the pelvic urinoma will happen. So the management, so basic management will be the catheter drainage that we do. Okay, so we'll put a catheter into the pelvis and we'll drain out the urine that has come out. Okay, so that is the thing. Then if it is a intraperitoneal, so it is because of a direct blow on a distended bladder. Okay, so what happens is, if we give a blow to the, or some injury RTA has happened, the bladder was filled, so that this is how the intraperitoneal rupture might happen. So the patient presents with severe pain and syncope might have happened because of the vasovagal maneuver. Okay, so how do we manage is based on laparoscopic or laparoscopic repair. Okay, so basically the bladder has torn out, so we'll have to go and repair it. So this is how we manage it. Then coming to urethral trauma, so the urethral trauma can be divided as two types. Okay, so see, urethra has 4 different parts. Okay, so one is the prostatic part, the membranous part, then the bulbar part, and the penile part. Okay, so the trauma can occur in any 4 of the region. So if it is the prostatic or the membranous part, it is known as posterior urethral trauma, whereas if it is the penile or the bulbar urethra, then it is going to be anterior urethral trauma. Okay, so if it is anterior urethral trauma, it is the clinical feature will be swelling around the genitals, and hematoma will be there. Okay, around it. Okay, so then blood at the meatus. So blood at the meatus will be on the, I told you, right, urethral trauma, meaning there will be blood at the meatus. Okay, so here in posterior urethric trauma, it is going to be difficulty in voiding because the urine can't come out, and again the blood at the meatus. Okay, so the management is basically, I told you, right, retrogradely we'll do the scopy, and the retrograde uretherogram is done, and we'll see where exactly the leakage has been, and then we'll do the suprapubic cystotomy, because here here we cannot allow the urine to go, so we'll have to protect the bladder also. So that is why we'll go suprapubically, we'll do one cystotomy and we'll connect the tube, okay, for the urination. Then after that, after a while, we'll do the repeated RGU, and we'll do the urethroplasty. Wherever the rupture is there, we'll do some urethroplasty. Okay, so this is the management of urethral trauma. Okay, then coming to urinary incontinence, the next topic with respect to how the whether the bladder is able to hold the urine, or whether the bladder is letting down the urine, both of it is a big problem. Okay, so that is why we'll see the urinary incontinence things. Okay, so urinary incontinence is basically inability of the inability to hold the urine, okay, in the bladder. What happens? Why does it happen? So let us see. Okay, so there are types. One is urge incontinence, stress incontinence, and overflow incontinence is what is happening. Okay, so in urge incontinence, it is going to be basically involuntary contraction of the bladder. Okay, so involuntary contraction of the bladder is happening, so which will lead to urination. Okay, inability to hold the urine. So how do we manage is basically antimuscarinics. So parasympathetic system is what is causing this involuntary contraction. So if we give anti-parasympathetics, so parasympathetic is what causes the excretion of the urine. If we give anti-parasympathetic, we are gonna hold the urine. So that is where antimuscarinics, especially the oxybutyrin. Okay, so please remember this name. Oxybutyrin is used for urgent incontinence, whereas for stress incontinence, it is because of the increased abdominal pressure due to some or the other things. For example, COPD, or there is a mass in the abdomen. So these all increases the abdominal pressure. Okay, so ascites and all these things, so will increase the abdominal pressure and cause the stress incontinence. Okay, so where we can use SNRIs or duloxetine. Okay, so SNRIs and duloxetine, the antipsychotics and all we discussed, right? So this is where we can give it. Then there is overflow incontinence, so there is some blockage in the urethra. Okay, so some blockage in urethra. So for example, let us take BPH, or some stone has happened, or some stricture has happened. So this might lead to overflow incontinence, where we can give cholinergic agonists. Okay, so cholinergic agonists can be given, that is bethanacol and all these things. Okay, bethanacol and alpha blockers can be given. So basically BPH. Okay, so we are trying to treat BPH here, and so basically in dementia and BPH, so basically we are going to give alpha blocker, especially please remember the name tamsulosin. Okay, so tamsulosin is very important. Okay, in Alzheimer's cases, we are going to go for trospium. Okay, trospium. Okay, so trospium is what we give in Alzheimer's. Okay, please remember the dementia, that is tamsulosin is what we give. Okay, then coming to the drugs that prevent the urinary retention. So basically we saw here, there it was inability to hold the urine. So now to prevent the urinary retention, what are all we are going to give? We are going to go for bethanacol. Okay, so that is the cholinergic drug, so to let the urine pass through. Okay, so once for all the urine should pass through, so that is why we'll give cholinergic, that is parasympathetic. Bethanacol will be given. Tamsulosin again to let the urine pass through, and it is not like again and again the person should go. So that is why once for all the patient should go. So that is why tamsulosin is given. And finasteride, please remember finasteride can be given in BPH. One of the best drug for BPH is finasteride, but it has a adverse action of causing gynecomastia. So that is one thing, because it reduces the testosterone. So in BPH this can be given, and also oxybutyrin. Okay, oxybutyrin we discussed, right? So can be given as anti-muscarinics. Okay, so this is the thing with urinary incontinence. Okay, so coming to the last few topics, that is we'll discuss the prostate, and then we'll go for the genital other genital pathologies. Okay, so with respect to prostate, benign that is benign prostatic hyperplasia, BPH, is very important, right? So mostly it occurs in more than 50-year-old males. Then the transition zone is the most commonly affected, which causes hyperplasia. Okay, so there are different zones in prostate. Transition zone is what is being affected here. Okay, so it basically compresses the urethra and causes all this urinary incontinence and all these things. Okay, so basically the clinical features will be increased urinary frequency. Again and again the person will be going, that too in the nocturnal time. So in the night time there will be increased frequency. Again and again they'll be waking up for urination. Okay, so this is the thing. Because of reduced urine passage, so the amount of urine that they are going to pass will be very less, whereas the frequency will be high. So that is why hydronephrosis, because all the urine is getting backflow. Okay, so that is why the hydronephrosis, which might lead to a complication of UTI. Okay, urinary tract infection also might be there. Okay, how do we investigate? So is based on USG, and we'll do the total PSA levels. Okay, so total PSA levels, why do we do is basically to determine how much BPH has happened, and if there is any cancer of prostate that is happened. Okay, how do we manage this? Alpha blocker, I told you, right? Tamsulosin. Okay, tamsulosin we were also using in dementia. Then coming to finasteride, the best drug, but the gynecomastia side effect is there. Or else we are gonna go for TORP. Okay, so we are gonna go and do a loop TORP. So where we'll be using the glycerol and distilled water is what we use, and just we'll crave out the BPH. Okay, so if suppose this is the urethra. So what we'll do is, so if there is a hyperplasia here, we'll do the TORP, meaning we'll ablate the entire thing, and we'll remove all the structures through water. Okay, that is distilled water or isotonic glycerol is what we use. So then coming to other prostate pathologies, prostatitis, that is dysuria, frequency of urgency, and then lower abdominal pain, and all these things will be there with prostatitis. So acute cause will be because of E. coli, and the chronic cause because of the bacterial or non-bacterial infections. Okay, then coming to prostate adenocarcinoma, I told you, right? So we are checking for TSA levels. So PSA levels, I mean, so it is basically in BPH only. So again, like more than 50-year people, it will be prostatic adenocarcinoma. Okay, so most commonly it is posterior lobe that is affected, whereas in BPH it was the transition zone that was affected. Okay, then clinical features is basically palpable nodules will be there when we do a per rectal examination. Okay, so then the diagnosis, basically the high level of PCA will be there. We'll do a core cut biopsy, and we'll do the Gleason grading, so that we can manage them. Okay, so the metastasis is to the bones, and the bone metastasis is by the prostatic venous plexus. Okay, so most commonly the spine is affected. Please remember this, the most commonly spine is affected, and it is the prostatic venous plexus that carries this metastasis. Okay, management of this cancer is basically NDA laser. Okay, then coming to genital pathologies. So basically STDs. Okay, so we'll discuss some of the very important STDs here. So STDs can be basically categorized into painless ulcers and painful ulcers. Okay, so the painless ulcers are so basically they will be usually will be single in nature. Okay, so granuloma inguinale, lymphogranuloma venerum, then the syphilis. Okay, so these are the three painless ulcers. Painful ones are cankeroids and herpes. Okay, so this is how you can basically categorize them. So all the organisms I've given here. Okay, so and also please remember the lymph node. So lymph node pain in lymph node, that is bubo. Pain of lymph node is known as buboes. Okay, so when the lymph node is involved in the infection, it is known as buboes. Okay, so lymphogranuloma venerum is where we'll be having a positive buboes, and also in painful it is going to be herpes that is having a bubo. Okay, so please remember that. Then coming to gonorrhea, Neisseria gonorrhea can cause urethral discharge, purulent urethral discharge, UTI we were discussing, right? So gonorrhea can cause this, and please remember gonorrhea. Okay, urethral discharge meaning that is gonorrhea. Okay, then bacterial vaginosis, candidiasis, and trichomoniasis vaginalis. Okay, so bacterial vaginosis, there will be fishy odor, and fishy and unpleasant odor. The discharge will be milky white. Okay, itching will be positive in case of bacterial vaginosis, whereas in candida there will be no odor. This is a fungal infection, so there will be no odor. Cheese like material will be there. Here also it is white only, but itching will be positive here, just like bacterial. Whereas trichomonas vaginalis, here also it is unpleasant odor, just like bacterial vaginosis, whereas the discharge will be greenish discharge, and there is no itching. Okay, so compared to other two, there was itching, whereas here there is no itching. So that is how we can diagnose the STDs. Okay, and then moving on to testicular pathologies. So it is please remember, so before going into testicular pathologies, let me tell you the kits. Okay, so there are kits for all these STDs. Okay, so if it is a discharge, see discharge we saw, right? So it is going to be Neisseria gonorrhea discharge, and all the bacterial vaginosis, all these things are having discharge. Okay, if there is a discharge, it is going to be kit 1 and 2. Okay, so kit 1 and 2, which is gray and green. Okay, so which contains azithromycin 100 mg. Okay, so this is what we are going to give. Then coming to ulcers, If it is a ulcer STD, we are going to go for kit 3 and 4, which is white, kit 3, 4 and 5, which is white, blue and red. Okay, so white, blue and red. So ulcers basically is what we are dealing with. So these are the compositions that these kits are having. Okay, then coming to lower abdominal pain, we are going to go for kit 6, that is yellow, which is having cefixime and metronidazole. Okay, then coming to bubo, I was telling like painful lymph node is there. It is going to be pain meaning black, right? So so it is a black lymph node, so that is why kit 7, which is containing doxycycline. Then the anal discharge, the new thing, please remember this. For anal discharges, we are going to go for brown. Okay, so stool is brown, right? So that is why we'll give anal, for the anal discharge brown, that is kit 8, which contains cefixime plus doxycycline. Okay, so this is how we can divide the kits into. Okay, so please go through this once again. So now coming back to the testicular pathologies, so one by one we'll discuss the hydrocele and varicocele. Okay, our final year exams, right? So hydrocele, so basically the fluid within the tunica vaginalis. Okay, so here just I am revising you. You probably would have forgotten. So tunica vaginalis, the fluid will be there. So the primary and secondary types will be there, and the congenital and acquired. These are the these are the classifications that we can do. Congenital, because there is incomplete obliteration of the process vaginalis that is there. So which might lead to hydrocele. Okay, so along with the hernia it might happen. Okay, so then there is acquired, where there is infection or torsion that had happened, and which or a trauma that had happened, and which led to hydrocele, the fluid collection. This is the most common type, right? So that is the thing. Then coming to primary and secondary is based on whether it is the reduction in absorption of the fluid that is happening, or the increased secretion that is happening. Okay, so if it is increased reduced absorption, primary. If it is increased secretion, it is secondary. How do we manage? Is basically Lord's plication, Jobel's procedure, and the herniatomy. Okay, so if it is along the hernia, it is going to be herniatomy that we do. So these are the certain surgical methods that we follow. Please know that we you know that, right? So we'll basically avert the scrotum and just tie it around the base. Okay, so that is what we do with these basic surgeries. Coming to varicocele, the most common we discussed, right? The reason why is it most common in left side. So basically a renal vein was there, and the gonadal veins will go and directly drain to the left renal vein, whereas on the right side it is directly going and draining into the IVC. Okay, whereas in the left side it is going to go drain into the renal vein and then get drained into IVC. So that is why here the junction, T-shaped junction, so there might be some issue. That is why the varicocele. Okay, so the worm bags can occur in varicocele. So this is the clinical feature. Then the management will be Palamo procedure. Okay, then coming to inflammatory pathologies of testicles, that is orchitis and acute epididymitis. So orchitis is viral and bacterial, whereas acute epididymitis is most commonly because of chlamydial infection. Okay, so the Prenz sign is positive here. So basically pain improves on elevation. Okay, so pain improves on elevating the scrotum is Prenz sign. Okay, so that means the Prenz sign is positive. Okay, coming to vascular pathologies, so basically testicular torsion, that is because the most commonly the high risk is because of the high investment of tunica vaginalis. Okay, so high investment of tunica vaginalis can cause testicular torsion. There are three signs that are important, that is Denin sign, angel sign, and Prenz sign. So Prenz sign there in epididymitis it was positive, where here it is negative, meaning the pain doesn't improve on elevation of the scrotum. Okay, so that is how we can diagnose just by examining the testis. Okay, so just we can by examining we could know whether it is acute epididymitis or the torsion, because in both the things it is be painful, right? So painful, so this is how we can diagnose it. Okay, then coming to angel sign, so what happens is the affected one lies in the horizontal line. So basically, so testis should be in this position, but the affected side it will be in this position. Okay, so that is called angel sign. Whereas in a Denin sign, it means that the affected side, the testis will be higher as compared to the normal side. Okay, so that is how the Denin sign is. Okay, so please remember these three signs. Then coming to management, so basically emergency detorsion, emergency case it is, so that is why we'll do detorsion and we'll do orchidopexy. Okay, so that is the management. Okay, then coming to testicular carcinoma. So there are non-germ cell and germ cell carcinomas. Please go through all these types. Okay, it is not much of an importance, but please do go through. There are these testicular cancers have been very common these days. So that is the thing. Okay, so please note, very important note. Okay, this is the previous year question. So the difference was asked. So testicular cancer basically drains to the para-aortic nodes. Okay, para-aortic lymph nodes. Reason being, so gonads were internal abdominal, right? Just right next to the aorta is where the gonads develop. So then during the development is where they'll come through the inguinal canal and come to the scrotum, right? So that is why it was an internal abdominal organ. Okay, so that is why the lymphatic drainage is in the para-aortic lymph nodes. Okay, please remember, it is not the inguinal lymph nodes. So you will think that testicle is there here, probably it is going to inguinal lymph node. No, it is the para-aortic lymph nodes. That is where the testicular carcinoma will drain into. Okay, then coming to the examiner's favorite, that is a surgical emergency of Fournier's gangrene. What happens is, here basically there is mixed bacterial infection, not a single bacteria, but a mixed bacterial infection, microbes infection is there. So here, this is a surgical emergency. Go to see an image of Fournier's gangrene. Here, the entire genital region, the perineum, is getting a gangrene-like appearance. But here, the one of the most peculiar thing is, here the testes are being spared. Okay, because the testicular artery is not involved. Okay, all the other arteries around the perineum and this genital region is getting affected. But the reason why testicles is being spared, and even in our management of surgical management, we are not worrying about testes, is because testicle has a separate artery, that is testicular artery, which is not the common artery that is supplying this particular region. So that is why testis is being spared. Okay, this is a surgical emergency. We'll do debridement and we'll do hyperbaric oxygen and all. Okay, so this is known as Fournier's gangrene. Okay, so this is the previous year question. Please note this. Okay, then coming to penile carcinoma. So most high risk is because of HPV, human papillomavirus, the 2, 16 and 18. Okay, so this is a squamous cell type of carcinoma. The management is, there are different variations of this penile carcinoma. Management will be, for flat lesions, we are going to go for podophyllin gel application. And so basically what happens is, in the penis there will be various ulcer like, or the flat lesions and all will be there, or the elevation will be there. Okay, so that is how we can diagnose a penile cancer. And also cauliflower like appearance. So basically squamous cell carcinoma, right? So cauliflower like appearance and all will be there. Okay, so if it is a verrucous type, then we are going to go for partial penectomy. Okay, partial penectomy we are going to do. Okay, so this is all and everything you need to know with respect to testicular pathologies. All the urology topics are also done. So now we are done with the nephrology and urology. So now we'll go for the last and final topic, that is obstetrics and gynecology, and we are done with the entire MBBS, right? We have like covered all and everything, right? So we'll go for obstetrics and gynecology. Thank you.